Acute heart failure. Acute heart failure refers to rapid or gradual onset of symptoms under signs of heart failure severe enough for the patient to seek urgent medical attention. So this means that patient will have symptoms in such a severity that he will require hospitalization for sure. Then only it is labeled as acute heart failure. So it is of four types: clinical presentation of heart failure, that is acute decompensated heart failure, acute pulmonary edema, isolated right ventricular failure, and cardiogenic shock. So management of patient with acute decompensated heart failure. Suppose patient have presented with acute decompensated heart failure. So if first you have to see is whether the patient have any symptoms of congestions or fluid overload, whether it is there or not. Next, if the congestion is present, then you have to see whether there is hypoperfusion or not. So hypoperfusion is assessed by assessing like any perfusion, if there is decreased perfusion to any of the organs. So suppose a patient have altered mental status, that is her brain is hypoperfused, he has oliguria or decreased urination, that means kidneys are hypoperfused, or there is peripheries are cold, then it means that it is hypoperfusion. So suppose there is hypoperfusion also present, then you have to start him on loop diuretics and also consider inotropes in these patients. So hypoperfusion and congestion is relieved after using the diuretics and inotropes. If yes, then you could put them on optimal medical therapy, that is heart failure treatment. As we already know, there's all those beta blockers, SGLT2 inhibitors, ARNIs, all these things can be used for medical therapy optimization. So suppose the patient has not, after using the loop diuretics and inotropes, the symptoms are not relieved, then you have to consider vasopressors like norepinephrine, which is a class 2B recommendation. And suppose even after this using noradrenaline also there is persistent hypoperfusion or organ damage, then you should consider it for mechanical circulatory support or renal replacement therapy in this patient. So suppose there is no hypoperfusion. So suppose hypoperfusion is absent, that is patient is maintaining BP quite well and there is no signs of hypoperfusion, then the class 1 recommendation is loop diuretics. You should continue in this case. So you should give drugs only for relieving the congestion. Congestion is relieved, then you should optimize the medical therapy. If it is not released, then you have to increase the diuretic doses or you can combine with the other diuretics. So then also if it is not relieved, you should consider for diuretic resistance or end-stage renal failure. Then the patient should be considered for renal replacement therapy or palliative care. So management of patients with pulmonary edema. Suppose the patient is only on pulmonary edema and without any features of any congestive heart failure, then it is so only have pulmonary edema and there is no congestion. Then it is a difference between the acute decompensated heart failure and pulmonary edema. So in this case, you have to give oxygen or ventilator support if required. So next you will check is BP, blood pressure. If it is more than 110 millimeters of mercury, then you should give diuretics as well as vasodilators. So what will vasodilator do? Vasodilator will decrease the preload and afterload and thus helps in relieving this pulmonary edema. So suppose there is there is BP is not more than 110, or then you should check for if there is any signs of hypoperfusion. As I've already discussed, hypoperfusion signs of altered mental status or decreased urination. If such features are there, then you should go for loop diuretics. Give loop diuretics and along with that you should start on inotropes or vasopressor. So suppose congestion is relieved, then you will optimize the medical therapy. If it is not relieved, you should consider for mechanical circulatory support and renal replacement therapy. So in patients of isolated right ventricular failure, so first you should look for the cause of right ventricular failure. The most common cause is acute coronary syndrome with right ventricular involvement, or it could be acute pulmonary embolism. If yes, you should treat specifically for acute coronary syndrome and pulmonary embolism. If you do not find any of this cause, then you should optimize fluid status, and then you should check for marked congestion, whether congestion is there or not. Whether if there is a lot of congestion is there, then you give loop diuretics. If there is no congestion, you should consider careful fluid administration. Next, check for if there is after that also diuretics also if there is optimizing fluid status. If there is persistent hypoperfusion and persistent hypotension, then you consider vasopressors or inotropes. If the signs and symptoms are relieved, then you just do a follow-up. If it is not relieved, then you should consider for right ventricular assist device under renal replacement therapy or consider palliative therapy. Management of patients with cardiogenic shock. If any patient with cardiogenic shock, first try to rule out the cause, whether it is acute coronary syndrome or any mechanical complications like ventricular septal rupture or free wall rupture of the heart. If those are there, then you should take for emergency PCI or surgical treatments. Like the specific treatment should be done. If it is not there, then you identify and treat other specific cause. You can consider oxygen and ventilatory support, inotropes, and short-term mechanical circulatory support. So management of diuretic therapy in patients with acute heart failure. So suppose a patient has came with acute heart failure. First, you should see whether the patient is already on oral loop diuretics. If already patient is using oral loop diuretics, then you should start him on IV diuretics, and the dose should be 1 to 2 times of the daily oral dose. So suppose the patient is using furosemide of 40 milligrams daily, then your IV dose should be in per day dosage of IV should be either 40 mg or 80 mg in divided doses. So suppose the patient is not on any oral loop diuretic therapy prior, then you should start him on 20 to 40 mg of IV furosemide. So after starting that, giving a dose of 20 to 40 mg of IV furosemide, you should after 2 hours you should check urinary spot sodium, and or urine output you should check after 6 hours. So after 6 hours, if the patient urine output is maintaining of 100 to 150 ml per hour, or urinary spot sodium is more than 50 to 70 milliequivalents per liter, yes, then you can repeat similar dose, that is IV every 12 hourly. Every 12 hourly you can give the similar dosage actually. So suppose this target is not achieved, then you have to double the dose IV until maximum IV dose you can reach. You have to reach that so that your goal should be this. So continue until complete decongestion this one, and check serum creatinine and electrolytes at least every 24 hours. If this therapy is not reached, then target is not reached, you can plan for combining diuretic therapies, that is use thiazide diuretics along with loop diuretics. Other recommendations in acute heart failure is oxygen supplementation should be given only if SpO2 levels are less than 90% or if PaO2 of less than 60. Intubation is recommended for progressive respiratory failure. Despite suppose the patient is already on non-invasive ventilation and is still not recovering, then you should consider for intubation. And non-invasive ventilation should be considered in patient with respiratory rate of more than 25 breaths per minute with SpO2 of less than 90%. Diuretics, intravenous diuretics are recommended for all patients with acute heart failure admitted with signs and symptoms. And if you are suspecting if there is resistant edema, then you should combine it with diuretic. Vasodilators should be considered in patients with acute heart failure if there is SBP of more than 110 millimeters of mercury. This is a class 2B recommendation. Inotropic agents should be considered only if the patient's BP is less than 90 and there is evidence of hypoperfusion, then only you should give them on inotropic agents. Otherwise, routine administration of inotropic agents is not recommended. Vasopressor, preferably if you have to use in cardiogenic shock, the preferable drug is norepinephrine. So these are the inotropes and vasopressors which you can use in acute heart failure, that is dobutamine, dopamine, milrinone, inoximone, levosimendan, norepinephrine, and epinephrine. All patients, since all these patients will be on either ventilator support or in ICU and they are immobile, thromboembolism prophylaxis for DVT prevention should be definitely given. And recommendations for maintenance or optimization of guideline-directed medical therapy during hospitalization. So suppose patient is already on a guideline-directed medical therapy, that for heart failure he is already receiving therapy. So now he has come with acute decompensated heart failure. Pre-existing therapy should be continued and the dose should be optimized to improve outcomes unless contraindicated. In patient experiencing mild decrease of renal function, suppose his creatinine has slightly raised or patient has having asymptomatic reduction of blood pressure during heart failure hospitalization, diuresis and other guideline-directed medical therapy should not be discontinued. So we tend that BP is falling, so we start decreasing the drugs, that is ACE inhibitors or ARNIs or beta blockers. So this discontinuation should not be done and this should be continued as part of that. So in patients with heart failure with reduced ejection fraction, guideline-directed medical therapy should be initiated during hospitalization after clinical stability is achieved. So this is for those patients who has no prior history of heart failure, now has presented with heart failure with reduced ejection fraction. So first, your goal should be stabilization, and once the patient is stabilized, clinical stability, then guideline-directed medical therapy in the form of ACE inhibitors, ARNIs, beta blockers, mineral receptor antagonists should be continued. In patient in whom if there is discontinuation of guideline-directed medical therapy is necessary during hospitalization, suppose the BP is too low and you are not able to put them on this therapy, then it should be restarted once the patient is little bit stabilized. So additional therapy in patient with heart failure and comorbidity, you should give IV iron replacement in patient with iron deficiency. Suppose the patient have AF, you should plan for AV nodal ablation. And patient having obstructive sleep apnea should receive CPAP therapy. And patient with heart failure and hypertension, you should treat hypertension as per the guidelines. All patients of diabetes and heart failure should receive SGLT2 inhibitors. If there is any suitable coronary anatomy and EF of less than 35%, surgical revascularization has to be done. Thank you.